Yep. Can you hear me and see the slides as well?
Go ahead.
Yeah.
Thank you so much for the opportunity. I know we're running a little short of time, so I will try and get through this quickly. At the outset, I just wanted to say that a part of this research is supported by a grant from the Buncher Foundation from Pittsburgh. So this is something new we've done in the last year or two, is starting sort of a dedicated study clinic for patients with CVI or cortical visual impairment. The initial part of the presentation really was about what is CVI. I'm going to skip that a little bit because I think most of us are fairly aware. I'll just quickly mention that it is the leading diagnosis for visual impairment in children under the age of 3. And as we all know, it's a large spectrum, including poor vision, complex visual processing issues, field defects, facial and space recognition issues, etc. And some of these children can actually have very good visual acuity, but have some higher processing issues, and so are often difficult to diagnose. The commonest cause is perinatal or postnatal hypoxia or hypoxic ischemic encephalopathy. Other causes include trauma, infections, metabolic and genetic causes, seizures, etc. This was a little bit about the pathophysiology of CVI. I think I will skip this in the interest of time. I was going to talk a little bit about the dorsal and ventral streams. They're basically the two streams that are supposed to sort of complement the primary visual cortex in our understanding of visual processing. So I'm just going to skip this a little bit. The diagnosis of CVI is fairly a clinical diagnosis. It's a lot to do with you looking at the child, talking to the parent, and a very detailed history taking. There are several caregiver questionnaires that can assess, that can assess various aspects of visual functioning. One of the common ones used is something called the Insight questionnaire that was developed by Dr. Dutton in the UK. There's another 12-question short questionnaire, and the CVI range, which was just, invented by Dr. Lansky in the United States. A complete ophthalmic exam, obviously, the visual field assessment, electrophysiology, and neuroimaging. A little bit about the Insight inventory. It has 52 questions which refer to visual, perceptual, and motor difficulties. It's divided across 6 domains. So it's visual search, visual fields, visual attention, perception and movement, visual guidance of movement, recognition, and navigation. And then there are questions asked, and the caregiver will rate from 0 to 4 based on never to always. The way the questionnaire is designed is based on your answers. It can come up at the end with a tailored strategy based on the answers that the caregiver gave. The CVI range is an assessment tool used to determine the degree of CVI on a scale from 0 to 10, where 0 is no detectable vision and 10 is vision comparable to a typical sighted peer. In addition, of course, the assessor's observation of the child and interviews with the parents are used to come up with a rating. There are 2 ratings, rating 1 and rating 2. Rating 1 determines the extent to which the CVI interferes with functional vision. And rating 2, again, looks at certain specific characteristics like color, movement, visual preferences, latency, etc., and comes up with a combined score. Again, like I said, score is from 0 to 10. 0 to 3 is phase 1, which is most severe. 7 to 10 is as close to typical visual functioning as you can. So what we did differently was trying to set up the CVI study clinic where the children with suspected to have CVI would have a complete evaluation with an ophthalmologist. Typically, I do the exams for all of these kids. We have a teacher for the visually impaired who comes in once a month and does the Insights questionnaire and the CVI range. We have an electrophysiologist. All of these children get a VEP and an ERG. And then we also review the neuroimaging with our neuroradiology team. The clinical exam, again, assessing visual behavior, various tests to determine vision based on the age of the child, a complete eye exam, ocular motility exam, specific attention being given to nystagmus and strabismus, accommodation and convergence, and then, of course, a cycloplegic refraction. These were just some clinical pictures of what we might see in these children. The ones on top are a child with CVI with small pale optic nerves. And then below, we see a larger optic nerve with significant cupping. This is often referred to as pseudoglaucomatous cupping. This is not really glaucoma, but you can see these in children with PVL or periventricular leukomalacia. A little bit about the electrophysiology role. It's really useful in young infants who are not able to comply with behavioral testing. We typically do this to also check if there's any other cause for decreased visual function, such as a retinal cause. We do a full field ERG, a pattern ERG, where possible sweep VEPs, and then transient VEPs. We also sometimes employ multi-channel recordings of transient VEPs to identify if there is generalized dysfunction versus a unilateral dysfunction, which might be seen with hemianopias. We can also look for chiasmal dysfunction here. This is just an example of a pattern reversal VEP. The first one, this one here, if you can see my arrow, is a normal response to the various checker sizes, 50, 25, and 12.5. And then here is in a 4-month-old with CVI. And you can see as the checker sizes go down, the VPs get degraded, both in the amplitude and latency of the P100. A little bit about our initial analysis. We have, this was a few months ago, we have a little more now, but this is 28 patients. The mean age was 5.89. We were able to formally assess visual acuity in about half of them, so 53. About 1/3 have nystagmus, half have strabismus, and close to half have an abnormal VEP and optic nerve pallor. The average score on the CVI assessment was 5.79, and it ranged from about 2.5 to 7.75. We also looked at our subset of children 5 years and younger because there's very little data on the use of the range in that age group. And the average score was similar, 5.86. We looked at also the presence of nystagmus and strabismus and then tried to relate it with certain subdomains within the CVI range. And we found, as intuitively we can, this would probably make sense, is that children with nystagmus seem to have increased visual latency. They have field preferences and also more difficulty with visual guided reach and distance and spatial orientation. So that was significant. We've also tried to look at the two questionnaires, range versus the insight. And here we've plotted on the y-axis is the insight and the x is the range. And we found that certain domains, especially the visual perception and visual recognition, have a pretty good correlation. So the two questionnaires also seem to be looking at similar things, although they were designed in a totally different format, but they sort of point us in the same direction. So in summary, the idea is to have a comprehensive evaluation of all aspects of CVI, and then come up with individual plans for rehab and interventions in these children, coordination with parents and other services for the child. And we're hoping in the end to be able to collect data to correlate what we find clinically with what a teacher for the visually impaired might find with all these assessments, and then come up with sort of a classification that will help us better understand CVI. Thank you.
Thank you, Preeti. That was an excellent presentation. Really enjoyed it. I would like you to share